My name is Keith Braganza, and on behalf of my fellow board of directors at Prostate Cancer Support Toronto, I'd like to welcome all of you to this evening's presentation. For those of you who don't know our organization, we are primarily in the business of support and education. In addition to these type of awareness nights where we have a specialist speaker, we have peer-to-peer support meetings twice a month on the first and the third Tuesday of each month. And as you know, because of circumstances, we are now on Zoom. So if you're connecting today from somewhere else, you're welcome to join us on the first or the third Tuesday evening. Our volunteers used to visit prostate cancer patients and clinics at hospitals, but that has been stopped because of the COVID situation. Our volunteers used to visit the clinics and also meet patients the next day after they've had their surgery, just before they've been discharged from the hospital. So without any further ado, I'm going to introduce our speaker for today. Our guest is Dr. Andrew Matthew, and he's going to talk about the psychology of a prostate cancer diagnosis, the physical, psychological, and functional aspects of prostate cancer. Dr. Andrew Matthew is a lead psychologist at Princess Margaret Cancer Center in Toronto. He's a clinician investigator in the Department of Surgery, Division of Urology, and a member of the Department of Supportive Care. He's also an associate professor in the Faculty of Medicine, University of Toronto, in the Departments of Surgery and Psychiatry. For over 20 years at Princess Margaret, his clinical care and research has focused on urologic cancers, including prevention, treatment, decision-making, sexual rehabilitation, survivorship, and patient quality of life. He is married with 3 sons, an 18-year-old and 14-year-old twins. That results in his wife stating that she's had enough of testosterone for a lifetime. He likes working with patients, but dislikes writing research grants. He likes artichokes, but dislikes eggplant. He likes kayaking, but dislikes canoeing. He likes wearing stretch jeans, and he dislikes wearing ties. And of course, he likes his friends at Prostate Cancer Support Toronto. And on a side note, some of us in the group today, in the audience, are involved with Dr. Matthew at the True North Peer Navigation Program, and that's how we work very closely with him in that program. So without any further ado, Dr. Andrew Matthew.
All right. Thank you so much, Keith. And I'm just going to share my screen, correct? All right. Well, I just want to start off by saying, obviously, it's a real pleasure to be speaking at tonight's awareness night for the Prostate Cancer Support Toronto. It's amazing when I look at all the faces on the screen, how many of you I know and I've known for, in many cases, a very long time. So it really is a pleasure to be here. If you note my bio was a little different, that's because Ron Benson said, you know, can you make your bio a little bit more exciting than he's of this and he's of that. So it is very true. I do love artichokes. And so there's a little personal note about me. Tonight, sometimes I get asked about talking about just the psychological aspects. Sometimes many of you know that I'll talk about sexual health. In some sense, I thought that I would do a broader talk so that it opened up some opportunity for discussion. I think a lot of you who have had prostate cancer and been treated for it are very good at discussing these various situations, and including sexual health and urinary health and whatever. So I think it'll give us a real opportunity all to talk. I saw a colleague of mine, Richard Wassersug's face. So welcome, Richard. Nice to see you. And I look forward just to all of us getting a chance to discuss these things. But I thought I would really start with a kind of overview, especially if there are new people here today, who are just learning about their disease. So to start off, right, the simple, what is the prostate here? We can see the prostate is right here. This is the bladder. This is the urethra. If you can see my arrow, and obviously this is the seminal vesicles, the testicles here, and the urethra goes right through the bladder there. Or sorry, right through the prostate there. So the primary function is to produce fluid that nourishes and transports the sperm. So at the time of ejaculate, 98% of that fluid is really fluid that's created from the prostate, and it serves to kind of lubricate and transport the sperm, and even nourish the sperm when outside of the body. It's estimated about 23,000 men will be diagnosed with prostate cancer. 5-year survival rate as high as 98.8%. That's the latest coming out. I think it's a little bit high. It's probably closer to 95%. 5-year survival rate. Over 20,000 men are added to the survival pool every year, with approximately 250,000 men who are survivors of prostate cancer. So in terms of just the diagnosis and the experience of diagnosis, patient's reaction, it was like a deer in headlights. I don't hear anything after the word cancer. I just felt numb. And it's a little bit of a reminder that this occurred just after, after you've gone to your GP. Oftentimes you've learned about your PSA is elevated, and you're told that this may indicate a problem with your prostate, so you're sent to a specialist. You might have even received a DRE at the GP level. Then you're sent for the biopsy, which all of you remember is not the most comfortable procedure. And then you're returned to your either your specialist, your urologist, to find out the results of that biopsy. So there's still a long journey, but there's nothing actually like hearing the physician say, "I'm sorry to inform you that you have prostate cancer." And just hearing the word cancer, when we hear the word cancer, it creates a rather traumatic response in us. And not only is that true for the patient, but it's also true for people who are close and love that patient, and in particular, for instance, partners of patients. So it's always a reminder that it's very distressing for those that are close to the patient. Patient's reaction can be denial, numbing, confusion, isolation, depression, anxiety, anger and hostility, often towards, or can be even anger and hostility towards God for allowing, believing that this happened, and doctors, and then especially challenging for doctors that believe they're God. And so there can be some frustration there. But of course, the underlying experience is fear. In the DSM-4, what that refers to is the Diagnostic and Statistical Manual for the diagnosis of mental health disorder. And the DSM-4 is last version, DSM-5 is the latest version. But it was actually in the DSM-4, PTSD, which stands for post-traumatic stress disorder, is the development and characteristic symptoms following exposure to an event that involves actual or threatened death, including being diagnosed with a life-threatening illness. In the DSM-5, it was kind of downgraded in some sense. A life-threatening illness or debilitating medical condition is not necessarily considered a traumatic event. To qualify as traumatic event must be experienced as sudden and catastrophic. And so I'm okay with this transition. I thought it was very important to be in the DSM to recognize how traumatic it is to be diagnosed with a life-threatening illness. This kind of downgrading from PTSD to a lower anxiety disorder would be something like adjustment disorder. Adjustment disorders can even include things like adjustment to some kind of trauma, maybe even a divorce, for instance, or a financial crisis can also be something related to an adjustment disorder. But the idea being is that it's underlying feature, and you can think of it this as trauma. And we just don't think about it in the public that way. But as you guys know, when you go in and hear your doctor say it is traumatic in nature. So Dealing with trauma over time is as many of you may know, is actually complicated, and it takes effort. But the initial thing, right when you're diagnosed, the most important thing is to feel that you have a strong connection to a hospital, that you feel confident in providing good care. You need a knowledge of the disease. This is just right at the very beginning when you're assessing what does this mean, but you don't, but too many people will overwhelm themselves. So the knowledge should be from a vetted source, and it's just for an initial understanding of the disease, especially in prostate cancer, where you learn rather quickly that in most cases, prostate cancer can be treated successfully. Gather resources, definitely social support from your family and your friends, but also peer support groups, reaching out to something like Prostate Cancer Support Toronto, to learn from peers that have been through this. I work at Princess Margaret Hospital for over 20 years. I thought I would have a group to talk about what it would like to be diagnosed, only to learn that the group that was already in Toronto was doing such a wonderful job, and they still do so today. Also, you can, if you feel really overwhelmed, you can reach out to psychosocial support services within the hospital. Most cancer centers have that. Just to recognize that it's normal to feel overwhelmed in these early stages, but we're remarkably adaptive creatures. And as we slowly process it, within a few days, we start to feel like our feet are landing back on the ground, and now we need to be a little proactive on where we go. But remember, you don't have to solve everything within a couple days of the diagnosis. It's just getting an initial knowledge so that the fear starts to drop to some degree. Then you kind of move into the treatment decision-making phase. And that can be a challenging time for patients. That's because there's a lot of treatments that are available, all of which are very successful in depending on your stage of disease. So initial treatment could be active surveillance. So eligible patients generally, and this is from the literature, but also from practice at most of the cancer centers, no more than 3 cores of a biopsy. Biopsies are often 10 to 12 cores, no more than 50% per core. A Gleason score of 6, that's that level of aggressivity, and we can talk about that during discussion if you want to know more about what Gleason score means, but that's a very low Gleason score. It ranges from 2 to 10. Basically 2 to 5 is considered non-cancerous. It's precancerous maybe. 6 is the kind of first level where the mutation of the cell is considered cancerous, and then on up, and the higher it goes. PSA of less than 10, having localized T1C disease and a negative DRE, and you could be eligible for active surveillance. There's radical prostatectomy. It's about a 2.5-hour surgery. It's 2 to 3 days in the hospital nowadays. When I started, it was about 7 days, 6-7 days in the hospital. So we've made some advances there, not only in the talent of the surgeon, but the talent of the operating theater as well. Catheters in for a couple weeks. We also have a robotic radical prostatectomy. And you can see, interestingly enough, that's the surgeon. It's about a $5 million machine, and it costs a fair amount of money actually to keep it running. And when we take a look at kind of the robotic versus the open, they're not too dissimilar, and they're not really dissimilar in survival, and they're not too dissimilar in side effect profiles. Although, as surgeons are getting better at using the robot, it does suggest that there may be some benefit in the side effect profile, less problematic side effects. We can also talk about that. External beam radiation therapy. When I started, I would say for sure the gold standard was surgery, and then there was radiation. Back 20 years ago, there was conformal radiation therapy, and then 3D conformal radiation therapy, And then we move to a more advanced kind of intensity modulated radiation therapy where they can actually direct the beams in a more localized way. And also wherever they want to localize those beams, they can also make an area that receives a higher intensity of gray or a higher intensity of radiation to that area, and then less intensity in the surrounding area so that we're damaging, or there's less likelihood of damaging healthy tissue. And then we have VMAT, which is even another layer, another more sophisticated form of IMRT. It's approximately 40 days of treatment and 15 minutes per treatment. Brachytherapy you might have heard of, or seed therapy, same day surgical procedure, general done under a general anesthetic. Seeds are active for approximately 5 months, and you can see them here, kind of this depicted in the picture, where these radioactive pellets let off radiation slowly over a period of time, killing the cancer and the gland itself. Hormone therapy, I'm bringing hormone therapy up because it can often be used if there's a belief that there's localized metastatic disease or distal metastatic disease, or even those that are believed to be at elevated risk or a higher risk cancer. They may also augment another primary treatment with ADT. And in fact, at least in the literature in the United States, in cases in which they use radiation treatment, they will often add androgen deprivation therapy at the same time in order to be more effective. So that's about 50% of cases. So we talk about patients who are still going for primary treatment and cure, have radiation, and sometimes the addition of hormone therapy. And then they're the more sophisticated hormone therapies. The ones you're probably more aware of are Casodex and Lupron, and then the more sophisticated ones are abiraterone, enzalutamide, and apalutamide. So when we're talking about the psychological impact of treatment decision-making, there's really this kind of information overload. I have had, famous lines from patients are stating things like, I didn't go to medical school for 10 years to be the one making a decision about what treatment I'm going to make. And I fully understand that. On the other hand, we want to make sure that patients feel that they're partnering with the medical team in order to make the right decisions that suit that person's values and goals in treatment, and then utilize that information together. So the hardest part is knowing where to get information, and then also knowing when to quit, and also that missing piece of how to assimilate that information and integrate it into your own experience. So as I said, if you go see Dr. Google, you will be overwhelmed very quickly. So it's not a bad idea to follow some advice from your cancer center, or to go to vetted sites, or go to known large respected cancer centers and take a look at what information they have. And then the idea of how do I assimilate this information in a meaningful way? They have what they call treatment decision aids that are often available to help with that process, but also making sure that you don't go through this alone. You talk to your oncologist, you talk to physician friends. If you're lucky enough to have doctors who are friends who are doctors, they're excellent to talk to. Prostate cancer survivors and the support groups are also helpful. And the goal is to understand the probable outcomes of each of the options, to consider what your personal values are by clarifying preferences in terms of quality of life. The idea that although we know that these treatments generally will have a negative impact on sexual function, if sexual function is not something that plays a big role in your life, and if you're not that sexually active and you're considering other domains in your life, then things like ensuring that that you don't suffer from fatigue, or looking at the best survival option may come into play. So feel supported in decision-making, move through the steps in decision-making, and participate in deciding about your healthcare.
Does it matter?
And then, so really, in the end, what are the treatment outcomes? What's important? And that is that once again, by talking amongst your support group and gaining some knowledge, you get a critical mass. And that's where you really feel like, one, you know what you know, and two, you know what you don't know, so to speak, and you've tried to search that out and try to learn about it so that you feel confident in the decision you make. And believe it or not, that's a huge point. Not only feeling confident in the decision you make, but also confident in the care team that you're working with. The satisfaction with decision, realistic expectations, knowing what to expect, and what are the side effect profiles and how that's going to influence or impact you becomes important. Increasing feelings of control and also a reduction in treatment regret. And these are actual outcomes that are examined when we use systematic treatment decision aids. So then we take a look at treatment and early recovery. So now you've gone through, you've decided on your treatment, and you're looking at treatment and early recovery. One thing is to remember that you are being treated for cancer. So you need to make time and space in your lives for recovery. What I find is that in many cases, almost like in a place of denial, is that the patients will get diagnosed and they just seem to think that they can add that diagnosis on to the stressors of their everyday life. And of course, that can then put them in a place of being vulnerable to being overwhelmed. So make some space and some time in order to process not only the diagnosis and the treatment decision making, but be aware that it takes some time for the treatment. The treatment is quite invasive in terms of your body reacting to it, meaning that your body does not know that you've put your hand up for surgery or you put your hand up for radiation, and so it feels like it's being attacked. And under those circumstances, it's using all of its systems to protect itself, and that can cause a significant amount of fatigue. So make some space and time. Consider support networks for both the patient and the partner. Going on autopilot during this time is quite common, and what I mean by autopilot is you kind of feel numb. It's and in some ways it's adaptive. It's like, okay, I can't feel the full degree of emotional response to being diagnosed with cancer, so our bodies, in a way, try to truncate that experience so that you're a little bit on autopilot, and that way you feel less out of control and that you can continue to put one step forward in getting your treatment. And the other is that when we're actually being treated, it feels like we're doing something. We're doing something to get rid of the cancer. And so often this is a time of the least emotional distress because you're actually doing something. Once you come out of the treatment and you're in the recovery phase and the longer term phase, then you kind of have to think back on what's gone on and what this means for you in the future, which can be more distressing. So interestingly, it's a time of often least emotional distress, which brings us to the kind of next phase, and that's the survivorship phase. The definition of survivorship, I like this slide. It was something that was seemed to be more important a couple of years ago, but there was the idea is survivorship is from the day of diagnosis. Some people thought it was active treatment, and active treatment has included and you're free of cancer, or 5 years after treatment has concluded and you remain free of cancer. But my actual definition, my favorite definition of survivorship, is a patient in actually one of the awareness nights who put up a hand and said, Dr. Matthew, I don't love the term survivor as it being the predominant characteristic of who I am, which I couldn't agree more. And he said, please don't call me a cancer survivor until I die of a heart attack. And I thought that is a pretty strong definition of survivor. So in essence, though, I think the real trend has moved towards a survivorship is the period from day of diagnosis forward. What you can see from these prostate cancer treatments is that they have quite high survival rates, which is phenomenal, but all treatments have very similar, or sorry, all treatments have side effects, both acute and chronic associated with them. We took a look at the long-term impact on quality of life following a radical prostatectomy. We took a look at the number of domains that we know are likely to be involved in patients that are treated with treated for prostate cancer. In this particular case, it's after a radical prostatectomy. That was the study we were doing. And what we want to do is we want to take a look at which domains are involved, and not only that, the severity of impact. And so what we found was that the percent of patients reporting no impairment at baseline, who also report no impairment at 18 and to 30 months. So why this is important is that it's not people that, you know, as you can imagine, people coming in after being diagnosed with prostate cancer, some may already have some bladder problems, some sexual function problems, emotional problems, urinary problems, and the like. What this study did was examine those that reported no impairment at baseline, and then saw how many returned to no impairment at 18 to 30 months. And you can see that by far and away, sexual functions is affected the most, then bladder control also, and referring to leakage in this case, was also seen. And then emotional well-being to a lesser extent, but just a reminder that a good 10% of patients have ongoing, relatively significant emotional challenges after their diagnosis, which we will talk to. If you look down here, urinary frequency, bowel problems, energy, and pain. Pain is usually not a problem post-treatment. Energy is more so than people think. It's not significant in this study because the energy at baseline was low, but it's still important to recognize that it is related to fatigue, and this may also be related to the psychological experience and of the trauma. So we also took a look at it actually in the prostate group, and so what happened is that we are taking a look at patient-reported outcomes where patients were filling out their information on the EPIC. The EPIC is a quality of life measure specific to prostate cancer. It stands for Expanded Prostate Income Composite. And so it looks at each of these domains that we also know that are affected. So here's urinary incontinence, urinary obstructive, bowel, sexual, vitality, and hormonal, all right? And then notice here, what we did is we said all comers coming in at less that had been diagnosed and had been treated less than a year ago. And I note that it is all comers. This wasn't experimental design. This was just an evaluation of how we were doing in collection of our patient-reported outcomes. So it's all comers, meaning all ages. We're not looking at nerve-sparing status. We're not looking at Gleason score or how severe the disease. It's just everybody that comes into the prostate center who had been treated within a year. And you can see that the red is severe dysfunction, yellow moderate, and then mild. And you can see here urinary incontinence is higher in the surgery group than the radiation group, which makes some sense. If we take a look over here, the bowel in the radiation group is struggling a little bit more than the surgical group. And then you can see a rather significant impact on sexual health, and then also radiation and surgery here. If we then take a look at all those patients that came in where their treatment was greater than a year ago. Now, remember, this could be, 55 weeks after treatment, or it could be 5 years after treatment. So it's not scientific in terms of that, but it really gives you a feel for, if you toggle back and forth, if I go to the before 1 year, you can really see that there's some impact in all of the domains, but then most of those domains reconcile, but yet sexual health kind of continues to be problematic for the groups. And remembering that age can also play a role in each of these. So, and there's even been research that's done where they've given this exact or given a quality of life questionnaire related to prostate cancer, not this one actually, to 600 men who do not have prostate cancer, an average age of 73 years of age. And you could see that they fired quite high in some of these categories as well, including sexual dysfunction. So, but just the idea of the domains that are affected and some reconciliation of function afterwards. So when we get to sexual dysfunction, it's certainly the number one side effect. The nature of sexual dysfunction is usually erectile dysfunction. It could be ejaculatory dysfunction, dry orgasms, or lower volume orgasms. You can have climacturia or leakage of urine at the time of orgasm, or anorgasmia, less common, but where patients struggle to have an orgasm at all. Loss of penile length, loss of libido can be related to the sexual dysfunction in relation to the treatments. It is the single greatest impact on a patient's health-related quality of life that needs to be justified to some degree by the idea that it's the sheer prevalence of the dysfunction. So almost all men going through the procedure will experience some rather significant loss of function, and it's related with bother. So a lot of dysfunction, and it's very bothersome. In terms of urinary incontinence, funnily enough, it's not as common, not nearly as common. However, if someone is experiencing significant urinary leakage, then their distress is very high. So it's not to suggest that other issues can't create a significant elevated emotional distress and its impact on quality of life. But just overall, if you take a look at the prevalence, sexual dysfunction is number one. So that makes some sense. Here again is the prostate. These are the nerve bundles, so to speak, that go down either side, the cavernous nerves. And when we treat cancer, either through surgery, we can damage or sever those nerves and interfere with erectile functioning. If we're using radiation, either external beam or brachytherapy, then we can also damage those nerves through the radiation, the gray and the burning of the nerves, blocking the nerve signal. So there's always a question, which treatment affects which side effect most, and that's a hard one to answer because, of course, it depends on another number of factors. But one kind of feeling here is if we look at sexual function, and here you can see what I've chosen is higher sexual function at baseline. So this graph refers to people that have pretty high sexual functioning, one, and two, also the radiation and prostatectomy groups have very similar baseline sexual functioning. And then they go through radiation or surgery, and you can see here that there's a bit of a difference at 2 years, and prostatectomy seem to have a greater impact. It's also important to note the kind of method of dysfunction. Radiation can cause some dysfunction, but usually doesn't start until about 6 months, and then it starts to decrease over time. Whereas surgical treatment will cause erectile dysfunction almost completely right after treatment, and then there's recovery over time as you get here. If you look over here, this is erection sufficient for intercourse is 2 years. Insufficient for intercourse in prostatectomies is about 70, almost 80%. In radiotherapy, it's only 60%. In 5 years, you can see it starts to catch up, and they become quite similar. And this is true for even the 15-year results. This is actually an older trial. It's the SANDA trial, and it takes a look at prostatectomy, radiation therapy, and brachytherapy. And you can see that in many ways they end up at the same. what you can see here is this one here in surgery is the nerve sparing procedure, and this is the non-nerve sparing procedure. So when there is nerve sparing, the recovery is much better than not. And here you can see that at the 2-year mark, there's some drop down in function. But really, I think it's important to note, look at the baselines of each of these. We have relatively high functioning individuals prior to the procedure in surgery compared to the radiation and brachytherapy. So the real feeling is that surgery will have a greater negative impact on your erectile functioning, certainly within the first couple years, than radiation therapy. There are the numbers: surgery 40 to 70%, radiation 25 to 50%, brachy 35 to 60%. And just to remember that other factors need to be taken into account. Pre-treatment erectile functioning, for instance, if we have full functioning prior to treatment, if we've had full nerve sparing, the younger we are, with fewer comorbidities, especially cardiovascular comorbidities, the more likely we are to have return of function. It's not only the prevalence, as I talked about just briefly, but also the level of distress. And in investigating this, about 60% of patients report moderate to severe distress related to erectile dysfunction. So when I'm asked to talk about the psychological impact of being diagnosed and treated for prostate cancer, it isn't separate from the side effect profile and the psychological distress related to that side effect profile as well. So that's why I'm including this in this talk. In a quality of life study and 1 year post-surgery patients, only about 12% reported fear of recurrence, 40% reported sexual dysfunction concerns. So you can see that the level of psychological distress related to sexual dysfunction can be quite challenging. Distress is especially elevated in younger men. It has a significant impact on the partner and a significant impact on the couple as well. I'll briefly talk here about androgen deprivation and sexual dysfunction. As I said earlier, approximately 50% of patients that receive radiation will also receive neoadjuvant ADT. And there's the reports about 73% report erectile dysfunction, 94% loss of sexual desire. This is that instinctual sexual desire. So there are some men that have a memory of having the sexual desire. It's and so the desire comes from that memory, but this kind of instinctual testosterone-based sexual desire is lost. About 83 to 93% sexual activity cessation in relation to being on ADT, mainly because of that loss of libido or loss of sex drive. There's reduced arousal. Some papers will present a loss of sensitivity to touch when the testosterone is blocked or removed from production. Difficulty reaching orgasm or anorgasmia, and body image concerns. We know that patients on ADT can experience some breast growth, loss of body hair, usually on the legs and arms and back, genital shrinkage, and loss of muscle mass. We do have treatments for erectile dysfunction. The treatments for oral meds or PDE5 inhibitors are like Levitra, Cialis, Viagra, all of which are certainly something that patients should try if they're interested in trying to regain their erectile function after treatments. It's the least invasive form, and it is successful in about 30 to 60% of patients. There's a broad range there because they really do depend on the nerve bundles, so it all depends on how successful the treatment has been in terms of curing you of the cancer, but maintaining the integrity of those nerves. Intracavernous injections, about 85, I would say even 95% effective. When they're not effective, most of the time that's just because the training on how to use them properly hasn't been available, or patients are just not injecting themselves quite in the way in which it can be effective and just need some retraining. Microsuppositories are about 50% effective. These are little tiny microsuppositories of medication that you actually insert through the tip of your penis, and I'll be talking about that in a moment, but it's also effective. Vacuum erection device is effective and is a good recommendation for people that don't want to try any medications. And then penile implants usually as a last resort. But the approaches to erectile dysfunction treatment for both radiation and surgery are similar, just so you're aware of that. As we talked about, if the nerves are damaged, the penis is blocked, and so that can interfere with function. So we can often use pro-erectile agents like Viagra, Levitra, and Cialis. And of course, here's a little Viagra joke. If the light stays on for more than 4 hours, call your erectrician. So there's a little humor for you, best I can do. So PDE5 inhibitors such as Viagra, Cialis, and Levitra have two primary function in restoring erectile function. I'll just slowly talk about this, is that PDE5 inhibitors block PDE5 from breaking down CGMP. CGMP relaxes the tissue in the penis to open up so blood can rush into the penis. And if we keep the CGMP there over a longer period of time, there's more likelihood that blood flow will reach the penis and stay in the penis over time. So just that direct mechanism, and also they serve to increase blood flow to the penis as well. If we take a look at microsuppositories like Muse, it's really alprostadil or prostaglandin E1, and there you can see a little applicator here. This is the actual pellet. It's on the tip of the applicator. You insert the applicator into the tip of your penis and then release it with a little button here and massage it into your penis. And it's a localized agent, so it actually just draws blood directly into your penis through same mechanism of increasing CGMP in the area. The vacuum erection device is a good alternative, as I said, to non-medication approach. Requires a penile ring in order to keep the blood flow and the blood in the penis. Because we don't actually have natural blood flow there once it's drawn in and the penile ring is on, there's a recommendation to remove the ring within in less than 30 minutes just to get back natural blood flow, oxygen, and nutrients to the penile tissue. But during that time, or especially later on, several minutes into it, the shaft of the penis can get cold because it's not the warm blood flow that you get from the system. It is a bit cumbersome and lacks spontaneity. That said, patients that use them and like them love them. So it may be something that you consider. Intracavernous injections. We have Caverjet, which is prostaglandin, with Bimix, Trimix, just an addition of different pro-erectile agents or medications. Erections can be dose dependent. So we don't want erections to last over 4 hours. I don't think anybody does. And it can cause damage. So we want to be sure that this is done in consultation with a urologist or a physician, and that they teach you on how to do it properly and how to dose up. But done properly, it's 95% going to give you an erection firm enough for penetration. Penile implants, last resort, although they're quite sophisticated now. There's both rigid and semi-rigid. The semi-rigid are more popular now rather than a consistently rigid one. It's hydraulic and inflatable, and it's concealed very well. And you could actually see this is it here, and then there's the pump that puts the fluid into the tube here to help make the erection. And there's tubes on either side of the penis. Complication rates about 2 to 10%. Penis will be shorter, usually after surgery. Possible loss of sensitivity. And the other thing to consider is they don't last forever. That's meaning that they'll last a long time, but definitely consult with your physician about the length of time that they will last. I only put this slide up because many of you have heard of this as the Sexual Health and Rehabilitation e-clinic, which is funded by Movember, and it's running in a number of centers in Canada. Why I put this here is that it's a very complicated process going through sexual health recovery. And it's very difficult to do on your alone or just on the brief moments you spend with your oncologist. So consider looking for a clinic that can help you do this. This is an online clinic, but your hospital may have a sexual health program, and it's certainly worthwhile reaching out. If we look at then if we talked about emotional, or we talked about sexual dysfunction, then urinary dysfunction. And again, here we can see this is the study published in the New England Journal. And here we have normal urinary function at baseline, okay? And then after radiation therapy, and you can see how the urinary continence or urinary function is affected. And you can see here that there's a greater impact certainly right away in surgery, and then there's recovery over time, whereas not too dissimilar to the sexual functioning, radiation kind of is the gift that keeps on giving over time and can affect actual function. If we look here, 2 years, about 10% of patients will experience urinary leakage versus the 3% in radiotherapy. That's obviously to do with the, it's to do with the interfering of the prostate as a method of the prostate does play some role. It's got smooth muscle in it and will play some role in maintaining continence. But what's also important to recognize is that the degree of bother is actually quite low. 10% of patients are bothered by their leakage. And that's really because this 10% is probably the leakage isn't as severe as many people would consider. It's not like you're at a restaurant and you lose continence altogether. So if we take a look at urinary incontinence, most incontinent men will experience mild incontinence with very little impact on quality of life. Severe incontinence, as I said, is associated with significant distress. There is invasive treatment is usually delayed for a year. So they want to see how you're doing a year after treatment. Then you can see a urologist to talk about more invasive treatments and controlling that leakage. Also, just the reminder that Kegel exercises and strengthening the pelvic floor muscle may also be helpful. If we take a look at bowel dysfunction and we go back to the New England Journal, and you can see here that bowel function is really rarely affected at all by a prostatectomy. It's more affected by radiation therapy, which makes sense because the radiation is hitting the bowel and causing the disturbance. And here we take a look at prostatectomy and radiation therapy within 2 years, but the level of bother is low, again, because this does represent some urgency, but the idea is that it's not as severe as many people consider. So if you remember when I was toggling back and forth on those green lines, and what happened was that most of these other areas reconcile within a couple of years, and what you're generally seeing is just the natural, in many cases, natural aging process. And then we also took a look at emotional distress. Interestingly enough, there's an article, this was back in 2005, granted, but Ontario cancer patients living longer but want more social support. If you take a look at this, cancer survival rates in Ontario among the highest in the world. But more could be done to improve the experience of patients and help them navigate the system according to the province's annual report card. So patients that are receiving seemingly the best care in terms of survival, very high in the world, even those patients that have experienced that the survival, they're surviving their disease, are struggling with emotional support. And that is true enough. The hospitals, the cancer centers are not providing enough emotional support. I don't have enough professionals in most cases that can help patients cope with the trauma of being diagnosed and treated. One of the kind of most significant concerns that prostate cancer patients have above and beyond the emotional distress related to the side effect profile that we just talked about is fear of recurrence. And this is common and the single greatest fear that all patients have who have been diagnosed with cancer. And you can see this is a bit of a different number, just so don't let this panic you. What this is this is a collection of 5 questions that they asked patients after treatment about, at the varying time points about their fear of recurrence. And they compiled these numbers, these 5 questions, into a scale of 0 to 100. And 100 is good functioning, all right? And so what you can see here is that, interesting enough, that they have yet to be treated. They know they have cancer, and this is when they have this biggest fear of recurrence. Fear, will they be cured, number 1, and then will it occur, is the highest. And then, as you can see here, at 6 months and 12 months and 18 months and 24 months out, that fear of recurrence climbs and then levels off, but never, in some ways completely goes away. And that makes some sense. Oftentimes, we don't think about our mortality. And in fact, we've developed this kind of protection mechanism where we're omnipotent and that we're going to live until we're 90 plus, no matter what. And these things happen to other people. And that's not a bad fantasy we've created. If we were really aware, if we really contemplated the risk that we're all under all the time, I think we'd probably be, curled up in our bedroom in the fetal position. So believing that you're going to live a good long life, and as long as you're not taking advantage of your health, so to speak, as long as you're not smoking 2 packs of cigarettes and working in an asbestos mine, the idea is that that theory, that kind of fantasy of omnipotence, is not a bad thing to maintain. But oftentimes when you're diagnosed with prostate cancer, it's the first time you're forced to look at yourself as being mortal. And that can, as I've stated, can be quite traumatic. But as time passes, and you do feel as though you're going to survive this disease, the problem is that you kind of still fear the idea that this cancer or another cancer may return. So when we take a look at psychosocial support for fear of recurrence, remembering that we have coming off the autopilot, trauma is always processed and integrated, and that's the way we treat it. The idea behind that is that if you think about it early on, when you're diagnosed and you're driving up a highway and you look over and you see a sign saying, please give to Princess Margaret Hospital, and you've only recently been diagnosed, it will trigger emotions very similar to when you were originally diagnosed. That's because it's not processed. It means that you're still trying to work through the trauma of being diagnosed. Now, if we go 2 years out and you see you're driving down another road and you see a sign, please give to Princess Margaret Cancer Center, it can still trigger you, but the emotional impact or the level of distress will probably be lower than it was 3 days after the diagnosis. And what that means is you start to process that diagnosis and integrate it in a meaningful way. And I don't mean meaning of life way. I mean integrated in a way in which you can regain a sense of control, that you're not constantly at threat. It's kind of finding this new normal of recognizing, even from an existential perspective, that you're mortal. But here, what I find is really fascinating is that after years of talking to patients that have been diagnosed with all types of cancer, there's this sense of loss of carefree. And I know it's not an exciting word, but it's what most patients will describe. And that's that sense of being truly carefree, that there's no threat. And And that comes from the facing your mortality, and it just kind of sits back there. Now, the good news is with prostate cancer, the likelihood is you're going to survive, and we can bring it back to the back and have play a less role on an everyday, in your everyday life. But everybody knows, a couple days or a week before you get your PSA result back, good old scanxiety, right? And except in a blood test, we get nervous. Acceptance, adjustment, and adaptation is a way you accept the fact that that you've been diagnosed with cancer. You adjust for it immediately, and then you adapt over time. That's a long-term processing and integration. Consider going to a psychosocial oncology department if you're being overwhelmed by this fear of cancer, fear of recurrence. And a good way of detecting that is actually sleep. Right? Sleep is really, if you're having poor sleep or your sleep is being interrupted or you're waking and you're worrying too much, it's a really good indicator that you need some help in doing this. Also, engaging in distracting behaviors relentlessly. It's no problem to go out and chop some wood to clear your mind a little bit. But if you must be doing something all the time, because God forbid you sit still for a moment in your thoughts, then that's also an indication. So consider professional counseling. So unfortunately, many cancer centers haven't done a great job at looking at the actual patient experience across the board, and the hospitals are now, there's a zeitgeist now. It's in fact, in Ontario itself, Cancer Care Ontario mandated that hospitals and cancer centers cancer centers to collect distress data, patient distress data, to determine how they're doing, so to screen for distress. And then that kind of broadened to screen for other side effect profiles. And this is true in many of the hospitals that I work with across the country, including good old West Coast and Vancouver. So we get the outcomes. Why that's important is the patient's voice. The patient is actually describing what's going on. And if we're looking at a level of distress, then what do we do about it? And so if it's low distress, patient can engage in self-directed interventions or psychosocial volunteer interventions, or so education, so to speak, can be helpful. If it's moderate, then the clinic might be helpful. So the idea of not the oncologists themselves necessarily, but the clinic, the nurses, the nurse practitioners, the physician assistants, all might be able to help you with the moderate distress. And then high distress, you may require a referral to a specialized group like a fatigue group or a psychologist intervention or a sexual health intervention. All right. And an output may look like something like this. So what we have here is that good old Fred was filling out the form here, and then it comes in this expanded prostate index composite output, and you can see here's urinary incontinence, bowel, sexual health, and the like, and it's monitored over time, and it takes a look at the specific questions related to it, and you can see here that the patient is doing quite well all the way through, except for sexual functioning, where the quality of the erections are poor, and the overall problem with sexual dysfunction is causing distress. And so once that is established, then we need to offer a patient care pathway. And so the idea here is that if, for instance, something is going on in this domain and we have some distress or dysfunction in this domain, then this is the referral mechanism, and this is the referral mechanism for each of those. And that way, we're not just treating the patient as, we treat the tumor, not the patient, but instead we're kind of taking a comprehensive experience of the patient and making sure that we're aware in terms of what the patient, how the patient is feeling in each of these areas, or how the patient is functioning in each of these areas, and then referring out or responding appropriately. I put this up as the Prostate Cancer Survivorship Program. And so when we take a look at all those domains, psychosocial support is very important. And for all the reasons we just discussed, sexual urinary function, we have a face-to-face rehab clinic, but there's also the online program. An exercise program is highly recommended. Cancer exercise came into cancer through fatigue, and it seemed to work very well for patients experiencing cancer-related fatigue. But we've also recognized that it has benefit, certainly in mental health, and for patients on androgen deprivation therapy, as long as it can be safely done, it's my highest recommendation for those patients. Lifestyle and nutrition, just kind of giving some control back to the patients and what they can do to be healthy. And then the importance of community connections and community organizations or not-for-profit organizations like the Movember Foundation. But really, I rely heavily on community support systems, especially the prostate cancer support in Toronto, as it no one quite knows the experience of that entire journey I just took you on more than you guys. And that means patients and their partners. And so I think it's extremely important that patients reach out to these support groups. So I'll end there, and thank you very much.
Thank you, Andrew. And is the 5-year survival rate true for advanced metastatic cases?
No. What they're talking about is the Canadian Cancer Society gives statistics on each of the cancers, and when they're talking about that high level survival rate, they're generally talking about all forms of prostate cancer collected as one. So it's that high percentage. That said, though, prostate cancer is a very slow growing disease, even the most aggressive forms. And so when we talk about those later stage diseases, it's quite true that when you get to diagnosis and treatment, and the androgen deprivation therapies are very successful in kind of putting the prostate cancer in remission, or more specifically, to stop the cancer from growing any further and keeping it kind of in hibernation, so to speak. And so regardless of your diagnosis, 5-year rates are still very high, regardless of the level of aggressivity. That said, the lower aggressive cancers are treated more successfully for a longer period of time. And so it's quite common for patients to be treated for prostate cancer. The cancer never recurs and they die of something else.
He says urologists, that is the surgeons, tend to understate the likelihood of erectile dysfunction. Are there any standards for reporting ED occurrence, and can they be improved to better prepare a patient for the side effects of prostatectomy?
It's a good question. There's no standards, but there's guidelines. And so the idea is that, a few years ago, a decade ago, they would actually investigate patient or physician notes, rather, to see whether there was any documentation of the side effect profile being discussed. And if I go back 15 years and we take a look at the data back then, it was not uncommon there's no documentation of any real discussion of the side effect profile of any of radiation or surgical treatment by physicians. That's not to suggest that they necessarily didn't talk about it. They certainly didn't document it, and they didn't talk about it in realistic ways. It's much more common now and expected that physicians do talk about the side effect profile, and then the degree to which they can be specific to it. One thing to remember is that Pre-treatment, they can talk about it to some degree. It's certainly in radiation, that's true. But when they actually do the radiation planning, or when they actually perform the procedure, the surgical procedure, they can get more information about how much they feel they might have damaged the cavernous nerves. It's not simple because they're microscopic, but the idea is that they can have some estimate as to the degree of things being damaged. And so if we take a look at the prostate and we take a look at those nerve bundles, is that it's also not necessarily so black and white. People often think that, if you can see my hands, this is the prostate and these are the nerve bundles. They're kind of microscopic, almost like a meshing on the side of the prostate. And so obviously, if the cancer is near the edge and they have to take a nerve, then the physicians generally know when they removed or taken the majority of a nerve bundle. The oncologists do, and they know that if it's very aggressive cancer and they want to be focused more on survival than anything else, they might remove the nerve bundles altogether. However, you can be told that you have nerve sparing, bilateral nerve sparing. Both sets of nerves have been spared, but maybe not fully. So just some aspects of it might have been cut. And I think, so I think that's, it's important to try to get some estimate from your physician and specifically your oncologist about what they believe the side effect profile is pre-treatment, and then also some suggestion of what it might be from post-treatment after they've learned from the procedure itself. And I think, I believe you said urologist, but just to clarify, the person that really should be talking to you about this is your oncologist, just to give you the side effect profile, because they're going to be the ones that treating them. And I believe that's probably who you were referring to as your uro-oncologist. But there's only guidelines, not mandated specifications. Remembering that lots of factors come into play, so it's hard for physicians to predict. That said, it was certainly underreported in the literature. Many times it was reported that maybe 20 to 30% would be affected. When I first investigated this, I did a review of the literature, reported back then that it's much more likely that it's in and around 23 or 24% that get return of natural function.
HIFU treatment seems to be one solution. When can you recommend it? Profound Medical has a more advanced system. He's talking about the transurethral ultrasound, and he says, can you tell the pros and cons?
Well, HIFU is high frequency ultrasound, and it's true that, as a reminder, remember, I've just done this a long time. I can speak generally about these things, but certainly you need to talk to your oncologist about what's available. But what the idea is that a kind of simpler way of thinking about this is that prostate cancer is usually multifoci, which means that it's in several locations within the prostate. There are collections of cells that they can target, but there's often lots of little areas that are affected by prostate cancer. So it's not as amenable to kind of a lumpectomy, so to speak. And so breast tissue, from what I understand, is more inclined to be clumped together into a localized tumor site, and then they can do a lumpectomy. This is less available in prostate. So what they've done is they've developed certain focal therapies, HIFU being one of them, where they use imaging to get their best idea of where the highest collection of cells are, and then they treat that area. But sometimes it's recognized that they're not going to get all the cells, and there may be a need for retreatment later on, or a recognition that a different type of treatment may be needed later on. The purpose of these focal therapies is to try to control or get rid of the cancer with the least invasiveness, the least amount of side effect profile. So HIFU may or may not be recommended, more related to cancer volume, how the Gleason score, or how aggressive it is. And so the best thing to do is to discuss that with your oncologist, to say, you know, here are the standard treatments. There are these minimally invasive treatments. Are they available to someone like me, and would they be recommended?
How is fear defined, since every man he knows after treatment worries before his 6-month or annual PSA test?
Well, it's a very good question, and it's I want to think of it more as not defined by the medical community as much. Yes, we can ask certain questions, but think of it from your perspective. There was a time prior to ever being diagnosed with cancer that your fear of any kind of cancer or cancer recurrence just was very rarely present. Then after having cancer, even though there's a very strong likelihood in many cases that you'll be cured of your disease and you'll die of something else, the fear still remains. And and so if you think about what were your worries prior to ever being diagnosed, and what are your worries now, and the addition of the worries related to fear are the change. It's normal to worry. What we want to do is we want to make sure that worry doesn't interfere or cause dysfunction in your life. So if you think about it, what I say to patients is no amount of worry is going to change your PSA result. So if you can save all your worry till about 3 days before your PSA and focus on and not have the worry for the 5 months, 27 days prior to your appointment, that's good. No psychologist in the world or no mental health professional in the world is going to be able to get rid of that worry or fear that occurs near the date of your PSA, just because it is a threat, although the worry doesn't change that threat. So it's more about, does it cause a level of dysfunction? There are certain coping strategies, just like containing it for a period of time, but also just to be aware that if it becomes problematic or dysfunctional, if you worry too much about it, if it interferes with your sleep, interferes with your work, interferes with your the joy, things that usually brought you joy, that's when it becomes something that you might want to seek professional help.
He wants more information on Gleason scores.
So Gleason is a way in which we measure how aggressive the cancer is, and what that really refers to is the degree to which the cell has mutated. So let's just say for fun that this is a healthy cell, and it's got nice clear edges, and it's round and looks well differentiated. What happens is that as the cells start to mutate and divide, they start to change form, and the more their form gets distorted, the more aggressive the cancer is. And so what happens is the pathologist goes in and removes the core, removes those core of cells, and then examines the cells under a microscope and takes a look at how differentiated the cells are. This would be 0 on the Gleason score, and then slightly distorted is 1, and then 2, and then 3, and then 4, and it goes like that. What they do is it's actually an addition of 2 scores out of 5. They take a look at what is the most, I believe it's the most aggressive form, the most distorted form in there, or no, it's the most common cancer that they see in there. So do they see mostly 3? So 1, 2, 3, mostly 3 formed cells when they take a look at the cancerous areas? That's the first one. And then they say, is there another set that is more aggressive or different from that 3? So let's say take Gleason 7. The idea is they take a look at most of the cells are a 3, that's the 3. And then they take a look and say, but there are some more distorted cells, and that would be some 4. So they go 3 plus 4, that's a Gleason 7. Or they could take a look at it and say, when they take a look at it, they see mostly that it's 4 cells, but is there any other type of cells? Yes, there's some 3, that would be 4 plus 3 equals 7. But because 4 is more aggressive, because the distortion of those cells, what's happened is that the 4 plus 3 is a greater risk than the 3 plus 4 in a Gleason. The range is usually 6 to 10. 6 is kind of low risk disease. 7 is intermediate to intermediate high risk, and 8 and 9 and 10 are high risk disease.
What are you finding out about the impact of natural foods, including the use of herbs, in containing the growth or spread of prostate cancer?
It's a good question. It's hard to answer that question. It's hard to answer the question about kind of herbs or even nutritional influence. The idea is that it's very, very challenging research to do. What happens is that you need to really kind of do a comparison. So you have a certain set of people that eat a certain way, and then another set that eat in a different way. So the people that are on this, let's say the cancer diet, they need to adhere to that diet likely over a long period of time. And meanwhile, the one that is not on the non-cancer diet supposedly is eating as they normally would. The challenge is that sometimes the people in the control group are eating more healthy. Sometimes the people in the cancer group are not adhering completely to the diet. It also takes a long time, and there's so many confounding factors that kind of nutritional research is very challenging in regardless of type of cancer. And it's usually not fast acting. In other words, the idea of trying to eat in a specifically healthy manner to reverse your cancer or to take away active cancer, that's not really been shown in the literature, and that makes some sense. The likelihood, and this is my opinion, is that if there's a nutritional change, it's going to probably have to have occurred over decades in order to be protective in nature. That's not to say don't eat healthy. Eating healthy and in many ways is good for your fitness. It makes you more healthy so that you can cope with treatments for prostate cancer or recurrence of cancer. And then in terms of more specifically herbs, there was some interest in Chinese mushrooms at a certain point in time, but I haven't investigated that literature in too many years to really kind of report specific to the questions of the impact of herbs. Although just a reminder, that kind of research is very challenging to do.
Andrew, thank you. I want to say that's a fabulous review that you've given. But I have also, for the ADT book, recently reviewed as much as I could and as thoroughly as I could these issues about supplements and herbs for prostate cancer. And by the way, if people may know that there's a book for those who are going on androgen deprivation therapy and classes that Andrew runs as well. He's an author on that book, one of the many. All right, so at this point, people should be clear. There is no diet that is curative for prostate cancer. There are good diets that can reduce your risk of getting prostate cancer, but once you get it, you have to be clear that there's no, at this point, and as I said, we've recently reviewed all literature. There's no magic diet. There's no food that will necessarily help. And in fact, you really should be discussing this with your physicians. And the language here is challenging because when someone says, I'm taking a supplement, we think is that adding something. Supplements add things. So somehow they should be beneficial. If I can find the right supplements, they'll be beneficial. But that's an issue around language. It's not necessarily validated by the science. And in fact, when you're trying to have cells die, like with chemotherapy, some of the factors such as oxygen actually help to destroy the bad cells. So we can take antioxidants, and these are the good vitamin types of food that we're, the green vegetables and so forth that we should be eating to help us prevent oxidative damage to cells. But once we're trying to kill the cells, it's not necessarily clear that taking supplements that are antioxidants is even helpful. And I've seen recommendations recently which say that, well, we cannot show that they're helpful, and therefore we probably shouldn't necessarily be taking them when you're, for instance, going on chemo. So the biggest point I would say to add to what Andrew said is, one, that he's right. The research here is difficult, and there's reviews upon reviews, and they always come up with how the challenges of doing the research, just as Andrew Matthew said here. But it's also true that you've got to tell your doctors what you're taking, and don't necessarily assume that it was said to be help prevent cancer, that it will help cure cancer. That's my comment.
And it's very helpful, Richard, and given especially that you just did a review of the literature, and Richard is a scientist as well, just so you know. So when he's reviewing the literature, he's doing it with a scientific mind and a critical mind. So it's very helpful. And an example was, there was a description of selenium and vitamin E a number of years ago.
Yeah.
And there was this real look at the supplement with vitamin E with a rather remarkable dosage, so to speak. And the study was actually shut down because they determined that there was elevated risk for lung cancer in the group that was on the vitamin E. Is that right, Richard? Am I remembering that correctly? I think
it was the Neil Fleischner's study on selenium and vitamin E, where people thought these were good, and one of them was not good. It was actually bad. So this is why you've got to be telling your doctors. The most important thing I can say about supplements is don't consider them necessarily good because they're called supplements. I'll actually add one more cynical comment. If I haven't convinced you of that, and you're committed to taking supplements, then make sure that they're expensive, because it's actually been shown that the more expensive placebos are, the more effective they are, which is a rather cynical comment. But
and just in relation to that, because then we're talking, so supplements are nutraceuticals. So that's the thing where it's the quick fix, take a pill or something along those lines. There's also general nutrition, right, and diet. And I think that again, I agree with Richard that, if you have the cancer, trying to reverse that cancer through diet, there's just no evidence that that's available. But as I said, if we think about eating and exercise, not so much as reversing our cancer, right, but giving us a general overall better state of fitness, that better state of fitness behooves you for the rest of your life, whether the cancer comes back or not. The more or less sedentary you are, if you want to take a look at the literature on that and aging, it's remarkable, right? And so, I'm in my mid 50s, and the idea is that if I can already tell my metabolism is changing, and so the idea is you got to change your diet, and you got to and think about exercise, because that gives you fitness. And fitness is related to quality of life. Okay. And that's something you want to focus on. So it doesn't, when Richard and I are poo-pooing the idea of this is going to affect your prostate cancer, don't misinterpret that as being something that could be very healthy for you for many other reasons. And, I say these are like from 2011, but there are two videos, both by Mike Evans, who's a physician and researcher, and one's called 23.5 hours. And it's about, that's the exercise one. And he basically says, you can do whatever you want for 23.5 hours. Just give me 30 minutes of your day to do exercise. And something as simple as walking can make a huge difference. And Mike Evans is also a scientist. So he actually goes through the literature. Yes, it's 10 years old, but these things don't change a whole lot. So the idea is that 23.5 hour video is fabulous. And then by chance, because I was looking that up, I found his video on healthy eating. And he also does a remarkable job of going through the literature and helping explain in lay terms what he was finding. And his end result was, if there's anything, really you want to look at that seems to have some momentum behind it, is the Mediterranean diet. And so I think there's probably some truth to that. And so I'll leave it at that. The other, just the final thing is that patients on androgen deprivation therapy are experiencing a very different experience than patients that undergo localized treatment, where they have the treatment and then the treatment is over. Androgen deprivation therapy, if it's not done as neoadjuvant, but you're on it for a longer period of time, then you have the side effects that occur over a longer period of time. And those side effects can definitely be challenging. And they weren't all referenced here tonight, by the way. And so there's a website in Canada called Life on ADT. And if you just go there, you'll find out more about what Richard was saying, the book. You have access to the book, but also access to the program Life on ADT. And I would suggest, and I've traveled all over the United States, there's nothing like it in any other country. It is the most sophisticated approach to understanding and helping patients understand what life is like on ADT. I run a class when everybody's in session, so to speak, not on COVID, but I run a class in this hospital that's based on, fully based on that book. And I feel it's my responsibility to do so. And I'm a senior lead psychologist, and the idea of taking 3 hours and teaching is not generally what I would do anymore. But I just don't feel that enough is done about it. And so I'll take it on and do it here. So I just wanted to mention that.
I'm blushing here. Thank you for plugging the program, Andrew. But I'll actually say, add, if I might cycle back to your stuff. When people often ask me, because I give talks to prostate cancer support groups often, what about taking blueberry juice? What about pomegranate juice? The questions about diet too often are looking for a miracle elixir, a miracle pill. And what Andrew said about exercise, you didn't point out how good exercise is for one's mental health. So I want to cycle back. I'll put a plug in for what you're doing, because Andrew collaborates with a gentleman, Daniel Santamina, who's Canada's probably expert on cancer and exercise. The hospital you guys all know about, Princess Margaret, is looking into exercise even before you're treated for your cancer, as how important it is. So if people are asking, what should I do for my lifestyle? What can I do for myself, for my own benefit as a cancer patient? Yeah, the Mediterranean diet, and get to the gym or get some exercise. I think it endorses everything that Dr. Matthew has said. Thank you.
Richard, since you had a question or a comment to make further down, and about ED, understanding of ED in the University of Michigan data. If you could just quickly touch on that before we go to the next question.
Sure. Andrew, the question came up about maybe 20 minutes ago. Along the lines of, why aren't the doctors being more honest with us about ED as a problem? And as you might recall, that our colleague in Michigan, Daniela Whitman, did a study where they were doing an educational session for patients before they went for their prostatectomies. And she gave them the numbers of how many were likely to have problems with urinary or erectile function. And then they ran a survey and asked the patients, how likely do you think you're going to be one of the patients who has these side effects? And there was a statistically significant difference. So I think there's a psychological issue here where the patients aren't always necessarily hearing what the doctors say. When this patient says, and this may not be true of the person who asked the question, but it can often happen that the patient wasn't expecting it to be as bad as it was, and therefore they block out the fact that the doctor might have told them. And we have to realize that that's an issue. So to do that research well, you really need to know exactly what the doctor said and not what the person thought the doctor said. We've seen the same thing with our studies with androgen deprivation therapy, where we've had patients and their partners go to see the doctor to learn about ADT. And then they've surveyed, we've surveyed, published, when they've asked the patients, now, what did you learn? We found there'd be statistically significant differences between what the patients felt they learned and what the partners felt they learned. So consults can be very difficult, and it's too easy to say, they didn't tell me this. But the proper solution for us is to go with someone who can take notes if we're going to be really scared when we're going for a consult. And I'd love to hear Andrew Matthew's comment on the response to that.
Well, I definitely, what you're referring to, and it makes a lot of sense, is that oftentimes when you're in talking to the doctors, most of the time, not for everybody, but there's kind of a hierarchy, right? It's, I want survival first. That's the most important thing, right? Not at all costs and for other cancers, but in prostate cancer, I want to survive, and then I want to make sure that I don't have urinary or bowel, because that can be very challenging. And then sexual health, and then fatigue, and then fear of recurrence. And so if we're really hyper focused and on survival, sometimes we're just not in the right headspace to listen to anything else. And that's partly what Richard may be referring to. Yeah. And then the idea is that that once they come out, and that's why that kind of contact at 6 weeks after treatment can be very important, because it's the idea that you're shifting from, okay, well, I went through it, my doctors told me that the pathology has come back and it's negative and my PSA is undetectable. Okay, so now what? How is everything functioning, and will I function this way for the rest of my life? So that's definitely true. And then as Richard said, not to suggest that the person asking the question, it is important for your oncologist to do their best to provide you with that information, so that you have some understanding of what the treatment's going to, how the treatment's going to impact you. It's referred to as informed consent. And so I can't say that the physician, as your question was, it's not that we tell the physicians, you must tell them that that the radical prostatectomy will result in a 75% chance that you will not have erectile functioning. It's too precise, and they can't. We don't understand the treatment and its impact nearly that and to that degree. That said, remember what I was referring is, let's get some good information up front, and you can get it from vetted sources, and that can give you some idea of having some realistic expectations, which is a term we use actually in prostate cancer in terms of ensuring that we provide that information such that we have realistic expectations. But also it's worthwhile going back and finding out what happened, right? And that way, at least from a surgeon's perspective, I know that they can be much more aware of what occurred. And, our surgeons will even say an approximate 70% saving of the left nerve and 90+% saving of the right nerve, right? And they'll give that kind of indication. And that's super helpful, because when I see it and I'm running a sexual health clinic and I get those kind of numbers, that can be helpful. That said, remember, that's even a guesstimation as well, because it's very hard for the surgeons to see these nerves at all, because they're so microscopic. Similarly with radiation, that we are getting so good at getting the radiation much more focal, so that it's hitting the prostate and doing less damage to areas surrounding the prostate. And that's why radiation and surgery are up at equal treatments. It's not necessarily that surgery is the gold standard anymore. We've got very advanced types of radiation done well. They have very similar survival rates, and then you can take a look at their side effect profiles.
Thanks, Richard. We still have some few questions to go. What is considered a high metastatic case?
What is considered a high metastatic case? I'm hesitant to answer that question because it's too broad a question, and you really need to know the details. So you need to know what your Gleason score is. So let me give you this: is that things that might influence that is the volume of your disease in your prostate. You want to know what your PSA level is. You want to know what your Gleason score level is. That's the one that I talked about before. And then you can take a look at imaging, and the obvious most common imaging is a CT scan and a bone scan. So the bone scan looks for metastatic disease in the bone, and the CT in the soft tissues. And then we have more advanced forms of imaging as well, PSMA PET scans, but they're only used under certain circumstances. So, and then the idea is that you can have what's called localized metastatic disease. So if this is the prostate here and the prostate bed in that pelvic region, and there's been some transition outside of the prostate, anytime a cell has left the prostate, that's now considered metastatic disease. And if it's left the prostate into a region, if that's called local metastatic disease, and the idea is that hopefully we may be able to still treat it. If it's outside of that area and outside at lymph nodes that are, for instance, it often metastasizes to lymph nodes. Some, not all lymph nodes are reachable by radiation or surgery. And so if it's farther outside that core, it's called distal mets, and that's a different form, or by location only, it's a different form of metastatic disease. So, but the question is that when you read about metastatic disease, it can be quite alarming. And so what becomes important is to have a really strong conversation with your oncologist to get a good understanding of your disease, how aggressive it is, where they believe it is located.
I lost erectile function years before my surgery. Can you explain why?
No, but there is, if it's long before your prostate cancer, and by the way, the prostate cancer itself is unlikely to affect your erectile functioning. So it's not like, it's actually our treatments that affect your erectile functioning. So why you lost erectile functioning a long time ago could be something that could be investigated. There is the kind of an experience right now where they see potential erectile dysfunction as a risk factor for cardiovascular disease because there's small blood vessels in the penis, and obviously they're peripheral in nature. And so if there's some, it can be an early indicator of cardiovascular disease. So you might want to check that out. I can tell you that by the end of this talk tonight, I'm going to get in trouble for talking like a medical doctor and not a psychologist, but I just want to kind of give you the general information, but be sure to go back to your GP or your cardiologist or your oncologist to find out more about these questions. It's kind of like, if you can forgive me this, is that you don't necessarily know what you don't know. So I'm trying to give you some information to give you some background so that you can figure out the questions you'd want to ask.
And he's talking about a scenario where there is a biochemical recurrence with a rising PSA, but the inability to pinpoint it. And therefore, there is a prospect of future treatment. And how do recurrence of initial fears and anxieties and all play in such a situation?
Well, when you have biochemical recurrence, like, and I'm guessing what you're referring to is your PSA has started to become detectable, which usually means that there's a likelihood that your cancer is in the very early stage of recurrence. And so what you want to do is talk to your doctor, and they'll give you, the oncologist will give you these kind of ranges where, look, it's so microscopic. Your PSA is only just detectable now. That's why we can't pinpoint where it is, because there's just not enough of the cells that are collected that we can actually image. So the idea is that your oncologist, he or she may say, look, what we want to do is we just want to keep an eye on it and keep an eye on your PSA. And then at a certain point in time, we want to initiate some systemic treatment like androgen deprivation therapy. And so physicians know when to do that. And there are guidelines and recommendations for when that should occur. And so that's what you want to look at. And then also ask your physician, at any point in time, are we going to be able, do you think, to image it so that we can pinpoint where it is to determine whether we can have another type of treatment focused on the recurrence. And there's, as I said, CT and bone scans, but the zeitgeist right now as well, depending on certain circumstances, is a PSMA PET scan, which you might consider talking to your doctor about. And then as far as the psychological experience, this is now not so much a fear of recurrence, but now it's the trauma or a re-traumatization, right, of having the cancer recur. And that goes you back into a kind of a state of that mortal threat, right? The idea that, it's back, am I at mortal threat? And that can be quite obviously distressing. And what you want to do is recognize that, one, as I said, no matter what's happening, this is not, we're not looking at it as that this is imminent, like something's going to happen right away and you better do something about it, right? It's much more, it gives you, there's lots of time to collect more information, get more data, get a better understanding of what's going on, so that you're not just thinking about, what your prognosis is. And that'll put you in a much better position to manage the cancer over time. And also, as simple as it sounds for me to say, we're unbelievably adaptive creatures. Just try not to get ahead of yourself. Go find out more about it and get the data points that you need to make some decisions about how you want to be treated.
On the radio, I hear advertising for a treatment to offset ED. Perhaps it's an ultrasound treatment, but I'm not sure. This was not one of your options. Is it still under testing? I guess he's talking about Revitamed.
Yeah, well, there are various forms of erectile functioning treatments, and one is this. God, if I know, it's called the ED2000. I think it uses ultrasound or electrical stimulation to increase erectile functioning or blood flow. To be honest, I don't know a lot about it, and that's it's not a common. It doesn't take a common place in the literature. So usually when we're looking at the literature in pro-erectile agents or devices, these ones that you're talking about, that you hear on the radio, they haven't actually kind of hit the prime time yet. That said, they've been around for a while, and so let's not throw the baby out with the bathwater. There could be some benefit, but I think the one is you want to talk to a urologist about it that specializes in sexual health and erectile functioning, and two is that if it promises a miracle, then it's it's unlikely to provide that miracle. There is no miracle treatments. So my suggestion is go and find out from a medical oncologist or urologist that you trust, and ask about this kind of treatment. The treatment does cost money, so it's not covered. I think it's not covered by OHIP and and hence it's out of pocket. So you want to make sure that you're getting value for your money.
Is there any way to cut down on urination twice during night and 10 times during the day?
Yeah. I think it's twice, when we take a look at, one of the things we want to look at is how much it interferes with your quality of life, right? And one of the things we really want to avoid is interruption of sleep. 1 or 2 times a night, that's okay, but you get above that and it's really starts to impact the quality of your sleep. And once the quality of your sleep is impacted, that can have much greater impacts on many other life aspects. So one, just monitor your sleep and see how it's going. And then if you're urinating 10 times a day and it's really interfering with your daily schedule, then I think it's definitely worthwhile to go talk to a urologist. Remember that the urologist that's treating you for cancer is called a uro-oncologist. So he's an oncologist or she's an oncologist, and they specialize in cancer. They're also urologists, so they have some good advice that they can offer, but usually under the conditions where we have urinary frequency that you're talking about that seems to be chronic, my suggestion is to go see a urologist who specializes in urinary function. And oftentimes those ones specialize in urinary function and sexual health. And there are ways of treating urinary frequency. It could be irritable bladder, and that's what you can find out from them. There are medications, but of course, with every medication, there are some side effects. So just what you want to do is balance how much it's interfering with your life and your quality of life, and what then will you be willing to do about it. But there are treatments. If you're that level of frequency is not common after surgery, but it may be more common after radiation, so that might play a role too. But I would absolutely suggest that you get a referral to a really good urologist.
Would you agree that part of the erection issue is that you can tell yourself after treatment that you're going to have problems, and this becomes a self-fulfilling prophecy? And how do you get past this?
Yeah. There's the way in which we take a look at erectile functioning is we take a look at organic factors. So is there some kind of insult that occurred that can cause erectile dysfunction, and then psychogenic factors, right? And how that may play a role. You can have erectile dysfunction that's solely psychogenic in nature. An example would be sexual performance anxiety, where you're so concerned about your performance with your partner that you're distracted and you're not focusing on the erotic nature of the experience. And without focusing on that erotic nature, you're not going to engage that very complex system of arousal, and you have erectile dysfunction. But it's also important to note that after prostate cancer treatment, invariably, the treatment has done some damage. And so there is a real experience that there's going to be some organic quality to it. And then what happens is that you start to not trust it, and you worry about it. You have a sense that it might affect your masculinity or performance-based, and you don't want to let your partner down. And so it's a combination of both the organic. So it's organic caused and psychogenically caused combined. And so what you might consider doing is talking to your urologist or sexual medicine physician. And for instance, when we treat people that have no treatment for prostate cancer, they just have what we consider psychogenic caused erectile dysfunction. That's the one that maybe, as an example, could be sexual performance anxiety. What we can offer them is a PDE5 inhibitor, which is may still be able to increase the likelihood of blood flow to the penis and increase the likelihood of an erection. And then confidence is built over time, and then they're weaned off a PD5 inhibitor like Viagra, Levitra, Cialis. My suggestion to you is that you go in and talk to the urologist, take a look at the pro-erectile agents and devices that are available, and work through them and see how you're responding, and see if there's enough of if the organic damage isn't so doesn't cause dysfunction, but has damaged your function, and hopefully some kind of pro-erectile agent will be helpful. If that's the case, you'll gain confidence again, and it could return. But I think it's hard pressed to say that you're under these circumstances willing yourself to, that your penis isn't getting firm. It's likely a combination, and you need some support. And when we treat erectile dysfunction, we treat it from a biopsychosocial approach for that exact reason, that it's not all just about can you get an erection or not. It's about how you approach it, how you manage trial and failure, because there will be times when it doesn't work, and it may not work 6 months after treatment, but it may work 2 years after treatment. So there's or you can try more invasive ones or not. So it's something worthwhile just to go in and check it out, and not assume that it's in your head only.
Can you comment on secondary cancers, especially after radiation, and how that fear can be addressed? Is there anything preventative?
Wow. Usually what happens is that I think my experience must be that prostate cancer is usually occurring later in life, which means that they have radiation treatment is later in life. And the radiation treatment is very focal, right? Like the idea is that it's very, they can tell the field of gray. So it's very focal. And so secondary cancers in response to radiation treatment for prostate cancer, I don't think are that common. I don't really, I've not really faced that in 20 years, that there's a common secondary cancer to radiation treatment for prostate. I know that radiation earlier on in your life, in when children and adolescents and young adults that are treated for cancer, there's a greater likelihood of a secondary cancer in response to the radiation treatment. But I think this is less common in prostate. So I think knowledge in this case is helpful. So it may be worthwhile just talking to your oncologist about, is this something that you should be concerned about? But it's not something that really flies up in my radar in the years I've been doing this.
Could cancer be related to a person's emotional health? And that's why medicine cannot find out the reason cancer started, especially trauma caused by death of a loved one or a divorce, etc., in addition to other environmental factors.
Yeah. Well, I think what you're looking at is that emotional experience and trauma and whatever causes the mind and the body significant stress. And that's hard on the body and its immune system. And they look at things like, it's not my area of research, but they take a look at cytokines and the like. Do I think that trauma and emotional distress is the single unitary issue that brings about cancer? No, I think that there are, there's over 100 different types of cancers from my understanding. And I think that the absolute majority of them we consider to be spontaneous, meaning that they come and we don't know the origins. But I don't think that emotional distress is likely the single origin for cancer, and certainly not prostate cancer. And the reason why I say certainly not prostate cancer is because prostate cancer is a very slow growing disease. It affects 1 in 8 men or something, or it's 1 in 7, 1 in 8, 1 in 9 men. So it's unlikely that prostate cancer stems from an emotional event or emotional distress. That said, there's a possibility that being stressed and emotionally overwhelmed may provide a greater opportunity for the cancer to grow, but I don't know that. And one of the things is to remember, and this isn't from the literature, but the idea is that, as cave people, I think our average lifespan was about 40 years of age, right? Or maybe 42 years of age or so. And now our average lifespan is in the 80s for men and women. And that's likely due to Western medicine, Eastern medicine, access to clean drinking water, access to food and shelter, good food and shelter. The idea is we've more than doubled our lifespan. And in some ways, you can think of it as that we just weren't designed to exist for as long as we're existing, and the cells are just breaking down. And that's probably more so true for things like breast and prostate cancer, just because, first of all, those are part of the reproductive system. The reproductive system in cave people was utilized decades before the 40s, their death. So, it's why and how we get cancer is still mysterious. That said, it's not in some ways surprising.
There are a lot of thank you notes, Andrew, from different people. They said that you've put things in very, simple language that everyone can understand, and a lot of them appreciate. Thank you. So that looks like that's the end of our questions. Before we end, I just want to remind everyone that our next awareness night is on Wednesday, the 28th of July at 7 o'clock in the evening. And on that day, we won't have a speaker, but we'll have what we call a survivor panel. So we have about 4 or 5 men with different types of experiences in their cancer journey, and they'll be on a panel, and you'll hear their stories, and then you can ask questions from any of them. And since there's nothing else, I would like to thank Dr. Andrew Matthew. We're very fortunate to have you, and you keep coming back and talking to our group, which is fantastic. Every time you come with new stuff, and it's always a great learning experience for us. In appreciation, we will make a contribution to Dr. Matthew's favorite charity, and keep this in mind. It's the Ernestine's Women's Shelter. So keep that name in mind in case you know of someone who may need help, either a child or a woman who needs help. So that's Ernestine's Women's Shelter. So thanks a lot, Andrew. Good to see you. And I guess we'll see you in a couple of days again on Friday. And thanks once again. A big thank you from all of us over here at PCS Toronto and the audience. And wishing everyone a good night, and take care, stay safe, and see you next time. Thanks, Andrew.
Really enjoyed it, everybody. Keith, we have to stop meeting like this. I look forward to Friday. I'll see you.
Yeah, actually, Sharon's sitting next to me, so she won't get suspicious.
Okay, good. Anyway, a real pleasure. It was a broad talk, but I thought that gave us a great opportunity to kind of have a global discussion. So I hope you enjoyed it. Thanks.
Thanks, Andrew. Good night. Good night, everyone.